I've been a member and a fellow of the college in many of its developmental stages for over 40 years. And in some respects, my career has mapped the evolution of the college to its current form. I remember how proud I was to become a member of the college when I was a clinician and nurse training school educator. And I remember the pride I felt when I was invested as a fellow. Under Rosemary Bryant's stewardship, I was invited to be the inaugural academic editor of the college journal. With my excellent editorial team and vast team of manuscript reviewers, I played a major role in beginning the incremental transformation of Collegian from a print-only, locally focused journal with shaky editorial control to what is now an international Q1 Elsevier journal. As I read over my editorials from that time, I think of them as some of my favourite, but probably least read, publications. I've sat where you are now, getting leave from work, sometimes with great difficulty and administrative tedium, to attend the college's annual scientific meeting. There is something in us, in you and I, that drives us to learn from each other, to advance where and what we are, and to enhance our practice. So I hope that today some of my words may prompt you to think in different ways about your place in the renewal of our profession and its readiness to respond to the demands of a new generation health service. We all know of the conceptual leaps that biomedical and computer sciences are making in developing products and therapies in clinical care. The growth of regenerative medicine and robotic and other surgical innovations are transforming healthcare. Wearable and implantable technologies are changing the way we diagnose, treat, and manage chronic disease. Pharmaceutical innovations have had a dramatic impact on the prevention, survival, and cure of many forms of cancer and infectious and chronic diseases. These welcomed advances in cure and management of disease, disability, and injury have created a new type of healthcare consumer. At a population level, we are older and likely to have one or more chronic diseases. Consequently, now more than ever, large sectors of the population are reliant upon ongoing monitoring and treatment support from the healthcare system. Many people are well informed about new and emerging health products and are seeking and demanding the best healthcare has to offer. But for some of us, the contrast between what is available and what is accessible is a shameful and tragic chasm. Our health system is challenged. The knowledge, procedures, devices, and treatments that are the products of healthcare innovation are being packaged, delivered, and monitored in systems of health service that are outdated. That is, despite changing consumer needs and the demographic and clinical profile of patients, we continue to do health service the way it has always been done, and that is a paradigm clash. In this health service context, nursing also has changed and evolved in accord with societal changes. So I'm going to briefly discuss three major changes in and about our profession that have, in combination, resulted in the crafting of new nursing, a composite profile of our profession that has incrementally changed on several parameters. The first of these is the emergence of a mature nursing science. Nursing has developed and is continuing to ensure a strong, unique professional science and evidence base for practice. Since the 1980s, when we moved into the tertiary sector, Australian nursing has been building research literacy and research practice. This has escalated over the decades to now where over 50% of our workforce have postgraduate qualifications and almost 20% have completed a master's degree. Our universities are also graduating high numbers of nurses with PhDs. National figures on this aren't available, but an example from my own university, Queensland University of Technology, our School of Nursing has graduated around 43 PhD students in 3 years, and to January this year from 2014, and a further 18 completions to date this year. Nurse researchers from universities around Australia have growing success rates in gaining funding in the highly competitive NHMRC and ARC grant rounds. These nursing researchers are making significant contributions to the ongoing development of an evidence base for patient care. And this is being conducted through health services and patients' outcomes research. Further to this, our leading researchers are on the world stage with international reputations in a range of fields, including chronic disease, workforce, advanced practice, and in the increasingly important field of implementation science. Our research base is broad. In addition to knowledge from systematic reviews and effectiveness and efficacy studies, nursing also has a strong tradition in discovery research. Our body of research that draws upon qualitative methodologies is providing much needed knowledge about patients and families and their experiences of health, illness, and health care. This knowledge is important for developing hypotheses and to inform patient-centred healthcare service planning. The consequence of this maturation of nursing science for our discipline, for nurses and patients, is substantial. With evidence to inform our practice and practice development, we have the tools, knowledge, and methods to practice with high levels of clinical effectiveness and clinical safety. We have a strengthened autonomy and logical frameworks for decision-making about patient care. And with evidence, we collectively and individually have unarguable autonomy over our practice. And this authority has primacy over orders, procedure manuals, and routine. The second of the three major changes is nursing service innovation. 20 years ago, nurse leaders in Australia were raising questions about the constraints and problems in health service. Waiting lists for specialist outpatients were getting longer and GP consultations were getting shorter. Elderly people and young families were presenting to emergency departments for primary care. In general, underservicing and timely access to quality health care was becoming a growing problem. These nurse leaders could see a future where nursing could make a substantial impact on the health service problems, and thus the nurse practitioner movement took hold in Australia. The nurse practitioner is, by design, a model of health service innovation. It is a workforce that is educated, agile, local, and ready to effect service improvement. This role is to date the most successful workforce reform model in Australia. More than that, it has gained a presence in the health service landscape and acceptance by consumers despite concerted resistance and obstruction from powerful interest groups. Whilst adoption of the nurse practitioner role in Australia was later than in many other countries, we made up for this in methodology and quality. Our inception of the role was systematic and based on a wide range of trials and demonstration projects across most states and territories, and was grounded in a nursing model of care. This focused, restrained, and research-informed introduction of the nurse practitioner service resulted in a robust legislative framework for implementation of the role. And this was closely followed by evidence-based nurse practitioner definitions and standards for practice regulation and education. Subsequent to this, an evidence-based platform for nurse practitioner role was established from nationwide research that was fully funded by the ARC in collaboration with all of the state chief nursing and midwifery officers. This research provided evidence, tools, and processes for nurse practitioner health service planning, workforce development, and ongoing practice audit. Australia is a recognised world leader in nurse practitioner service development and role implementation. The third and most recent major change that contributes to new nursing is that we now have a framework for professional nursing practice in Australia. We know our clinical nursing workforce. We are able to break down jurisdictional borders and speak about nursing titles and roles as a single profession, not fragmented and not divided by state and territory borders or by confusing and proliferating nursing titles. We have evidence-based information on the structure and service potential of nursing in Australia. With this information, we can achieve much to enhance the nursing discipline and its contribution to health service reform, and to regain governance over our profession. This development is the outcome of a 10-year advanced practice nursing program of research funded by the Australian Nursing and Midwifery Federation, the Australian Nursing and Midwifery Accreditation Council, and largely by the Australian Research Council, and supported by the Australian College of Nursing and member communities of the Coalition of National Nursing Organisations. In this research program, we initially set out to identify and define advanced practice nursing in Australia. We achieved this, and in so doing, we also derived comprehensive knowledge about all levels and practice profiles of the Australian registered nurse workforce. As with the other two elements of new nursing, the consequence of this development is substantial. We can now map nursing service to best suit the clinical needs of patients and clients, and we can define and measure advanced practice nursing and nurse practitioner clinical profiles. We have published tools that nurse clinicians can use to measure their own practice profile and make decisions about career planning, further education, or to support an application for an advanced practice nursing position. We have also developed and published a nursing workforce survey toolkit. This toolkit can be used by nursing service leaders and policymakers to develop real-time, reliable knowledge of the practice profile and service potential of the nursing workforce in their organisation or jurisdiction. And now, with this toolkit for the first time, researchers can measure and delineate nursing staff as variables in conducting patient outcomes research in health service settings. In addition, the Making Nursing Work theoretical model developed from this research program provides the basis for an overarching national nursing framework. This framework can harmonise the diverse arms of our profession, including service, industrial, professional, tertiary educational and research from a common theoretical base. This is a profound and important superstructure to support an integrated nursing discipline. So far, I've described what I see as new nursing. We are a profession and a discipline that has matured, evolved, and grown in pace with the fast-changing health industry, and we are central to that industry. I've articulated three major developments that have in combination brought about an evolved profession that is well placed to take a major role in addressing the current pressures and problems of health service. Yes, we have new nursing, but we do not yet have new nursing service. Excuse me. The people at the centre of health service determine the nature and volume of demand. It is the characteristics of consumers, therefore, that need to influence how and where we deliver healthcare. The population we're serving now is very different from the one our current system was designed to serve. The demographic has shifted, and it is no longer feasible or economically sustainable that acute care hospitals could dominate patient and community health care. Health service needs to be delivered where people live by a range of clinician providers, and patients need to take a bigger role in their health recovery and health maintenance. We are now at a stage where, as Barbara Starfield reports, it is now more important to know what sort of patient has a disease than to know what sort of disease a patient has. Reform is needed, and reform calls for innovative thinking. But true health service innovation requires courage and an acceptance of change that is, at its heart, disruptive. It requires policymakers to be bold enough to break conformity with tradition and vested interests and turn their undivided focus to the needs of people and communities, and in particular to the needs of the most vulnerable and marginalised. This is not happening. To give an example, governments at Commonwealth and state territory levels continue to seek solutions to problems in the health portfolio. And they do this by establishing reviews and inquiries conducted by key groups of health experts. Whilst the language and priorities differ across these reports, there is consistency in the issues identified: rising costs, ageing of the population, problems of timely access, fragmented care, inequity, and so on. These are weighty issues, and they bring hardship to consumers and communities, and problems for governments. And these inquiries are set up to devise and provide new ideas and innovative solutions. The deliberations and recommendations from these groups, however, are mostly safe and conservative and pay scant attention to service improvement through workforce reform models. Specifically, despite the centrality of nursing to health service, the diversity and depth of nursing expertise, the suitability of nursing's model of care for healthcare consumers, and the strong scientific base of our profession, nursing service remains largely invisible in the findings of these reviews, except as support to entrenched medical service models. One reason for this invisibility is the membership of these expert groups that advise governments are primarily medical doctors, with the occasional practice nurse and policy academic. Our CEO, Adjunct Professor Kylie Wood, commented on this in a recent college communique. It follows then that the recommendations from these reviews and inquiries will mainly reflect what is familiar and known within the expertise of the membership. For centuries, medical leadership and medical solutions have been the ready and relevant answer to most health challenges. But now the climate of the industry has changed dramatically, and it is no longer feasible or affordable for a single provider to meet or direct the healthcare needs of all sectors of the population. Under the prevailing model, we are at a point where health disparities have not improved. Access to service is increasingly problematic, and as a proportion of GDP, healthcare costs continue to rise. Nursing is not the whole solution, but it is an important part of the solution. A reform agenda needs to turn away from what we have always done. Australian health policy needs to reframe the approach to health service as authentic multidisciplinary care, so that medical solutions and medical care will also become part of, instead of the whole of, the trajectory of patient and community-focused healthcare. Our profession can play a part in bringing about change, but first we must have a seat at the table at all levels of government and health policy. Yes, this is about nursing leadership, and it is also about power. In order to be heard, our profession needs to speak with one voice. We need a message at the level of influence that strongly broadcasts a reform agenda at its centre, and nursing's potential to address the issues in our current health service environment. But you and I cannot sit back and be silent and leaving and expecting our professional, industrial and bureaucratic nurse leaders to carry out our mission. You and I also need to speak. Dr. Sanchuranda commented in a 2015 Collegian editorial that we nurses are silent, and our silence reduces the influence nursing could have on government health policy decisions. Because we are silent, nursing does not have a strong presence in the minds of communities, governments and policymakers. The actual nature of our profession and our potential is unknown and unexplored. With great apology to our health minister, how often have you sat in a forum like this with a dignitary or politician addressing the room, and they often open with, "My mother, sister," I wrote this 2 days ago, "brother, cousin, wife is a nurse." The subtext being, I learnt about nursing at the kitchen table. I have authority. I know nursing. Then this is really prophetic. Then they often belie this and proceed to talk about nursing in the context of medicine. As an audience in these forums, we need to challenge this with an informed and opportunistic narrative about the value and reach of nursing as integral to the healthcare system. We do at times rest on our laurels, confident in the fact that nursing is well regarded by the community. This is true. According to numerous polls, the public trusts us. Nursing consistently scores in the top 3 as honest and ethical professionals. Trust is good, but it's not enough. It is memorable to most people that when they are sick, vulnerable, alone in pain, sickness and fear, the person who is there to tend to them and their bodies is a nurse. But our profession should demand more from the community than trust. We need the community to know that nursing is a solid and comprehensive clinical science, that we are agile, adaptive and innovative, and well equipped to to address many of the pressures on health service. We must be loud, proud and strong about our profession. So to use a metaphor from the antiquity of nursing, we, you and I, are the foot soldiers for the message about our profession. We are out and about, on the ground, in touch through our patients, clients, their families and communities. We are in education, health service, health administration, clinical service and leadership roles. And we must speak about and promote new nursing and its role in a reformed health service. We must all make change happen. Thank you.